Hey everyone, my name is Dr. Michael Wald, the Blood Detective, and today's podcast presentation is entitled Health Dangers of Anemia, What Your Doctor Won't Tell You. And I mean it when I say that because when I went to medical school, I learned about anemias. Anemia basically means deficiency. They teach us about iron deficiency anemia because it's the most common anemia on the planet. But they rarely tell you about other anemias, and these are very severe anemias, and in my experience, people go years to decades with these uncovered anemias, suffering needlessly, and you won't have to just by listening to this extremely brief presentation. Once again, my name is Dr. Michael Wald, nicknamed the Blood Detective. I have a board certification in nutrition. I'm a doctor of chiropractic. I have a sports nutritionist certification. I'm a dietitian. I went to medical school, graduated, earned my MD diploma, but did not seek an active medical license. I provide acupuncture to my clients, and I'm also a life coach. Now, the information we'll be discussing today on anemias is for your education. It's not meant as a substitute for a sound medical or health advice. So what is anemia? So anemia is a condition in which the blood has a reduced capacity to carry oxygen, usually due to low levels of healthy red blood cells or low levels of hemoglobin. And in this picture you see here, these arrows are pointing to red blood cells that are anemic. They have that pale inner portion, and this is very common in an iron deficiency anemia. Now, what we need to know about all anemias, regardless of the cause, whether it's low iron, whether it's a B12 anemia, B6 anemia, vitamin C anemias, those are all anemias. We're going to go over each and every one of them. They will result in poor oxygen delivery from cell to cell and then thus to tissues in the body. So this oxygen shortage can lead to fatigue, weakness, shortness of breath, dizziness, and impaired cognitive and physical performance. Your levels of ATP production will be affected, and your ability to do lots of different types of work, even thinking, can be adversely affected. The anemia may result from nutritional deficiencies. Chronic disease can cause anemia by hyperutilizing nutrition. And also different diseases like some autoimmune diseases might cause autoimmune reactions, causing destructive hemolytic, which is a destructive change in a red blood cell, which will make someone suffer the signs of anemia. We'll talk about a little more about the anemia of chronic disease in a few minutes. And we want to identify the type of anemia because it's critical for effective treatment and prevention and for long-term care. And we want to recognize some of the differing signs and symptoms of various anemias. So generally anemias will cause these sorts of fatigue symptoms that I've mentioned here. But depending on the anemia, there are some special symptoms and signs. A sign is something the doctor sees on you or someone else observes, and the symptoms are what you complain of. So here's a couple of different forms of anemia. Iron deficiency anemia. That usually, I'm going to give you a quick review of these right here and now, and then we're going to go into them a little deeper as we move along. So iron anemia, as I mentioned, is the number one anemia on the planet. It's usually due to lack of iron in the diet or lack of iron relative to a woman who's menstruating, losing more iron than she's taking in. A person could have internal or external hemorrhoids and or bleeding anywhere in the body, like in the intestinal tract from, let's say, colon cancer, which can cause anemia. So if you're a man and you have chronic anemia, you must get that checked out right away, because you're not menstruating, so it might be something much more serious. And the same is true for women. Although if you're menstruating, that's likely it, which means that there are hormonal issues which are causing the iron anemia. And then there's vitamin B12 anemia, which is what we call a megaloblastic anemia, which simply means the cells, the red blood cells, become large, megaloblasts. In iron anemia, if you look at the cells microscopically, they are tiny. They're microcytes. So that's for iron anemia, and macrocytes for vitamin B12 anemia, folic acid anemia, even B6 anemia, all large. Even vitamin C anemia will produce large cells. So it's very important to look at your blood work under a microscope, just like I've shown these images in the back here, because what you see under the microscope can confirm what you suspect from regular laboratory work. And you've all had regular laboratory work. That's just counting up your red blood cells. But if you have a bunch of red blood cells stuck together from inflammation, let's say from an autoimmune condition, those several cells might equal one large cell, and it might, the machine that measures that in the labs might think that's a macrocyte, It's not a large red blood cell. It's a bunch of normal red blood cells stuck together. You can't know the difference unless you're looking under a microscope. There are lots of examples of that sort of thing where you must look under the scope as well. Why don't doctors do it? They're lazy. They don't do it because they're lazy. Even the American Medical Association put out an article and a statement years ago that it feels that regular practitioners are under appreciating peripheral blood smears. That's the microscopic test. So there's folic acid anemia, which is called a megaloblastic anemia, so the cells will become large. In vitamin B6 anemia, there's sideroblastic anemia. We'll get to that. There's protein anemia, vitamin C anemia, which usually produces large red blood cells. Anemia of chronic disease, which means that the disease causes an issue with one or more nutritional elements, which produces an anemia. And there's hemolytic anemia, which the term hemolytic refers to the red blood cells being broken up. So various autoimmune diseases do that. If you also have a enzyme deficiency of what's known as G6PD, that can be checked easily on your labs. If you have a deficiency of that and you take a certain amount of vitamin C, you can cause a very serious hemolytic crisis. And then there's aplastic anemia, sickle cell anemia, thalassemia, and pernicious anemia, which has to do with intrinsic factor, a compound produced in the intestinal tract, and how it helps the body utilize B12. So let's start from the beginning here. Iron anemia, mostly from blood loss through menstruation or gastrointestinal bleeding, or low dietary intake of iron, or maybe poor absorption of iron, or an increased demand of iron that we see in just growth and also pregnancy. So you'd want to look at these particular lab tests. As the blood detective, if I didn't tell you the lab tests that you need to detect these anemias, what good would I be? So we want a serum iron level. We want a total iron binding capacity, TIBC, a ferritin, which is a several month average of iron stores. That's what ferritin is. And we want a transferritin and a CBC, a complete blood count, which measures the red blood cells, white blood cells, platelets. The symptoms of iron anemia, commonly fatigue, pale skin, dizziness, and brittle nails is a giveaway. Here's B12 anemia. Now, if we look here at any of these red blood cells, that big thing in the middle is a white blood cell. Don't pay attention with that. The one that has these purple little circles that are connected, that's a neutrophilic cell with a nucleated nuclei. But all the cells next to it are red blood cells, and they're large. They're too large. So if a cell is too large, it doesn't work as well. It's kind of like a muscle that overworks in the gym. It gets larger with every rep, but it's less and less effective. Also, having large cells means that it's going to be harder for the heart to pump around those large cells. So a megaloblastic anemia caused by any nutrient, folic acid, B12, B6, for example, will increase cardiovascular risk. And so will an iron anemia, even though iron anemia causes microcytes, because that's an oxygen depletion problem, so the heart has to work a lot more there as well. And the cause of B12 anemia, the megaloblastic anemia, remember, megalo means big, blastic means big cell. So we have inadequate dietary intake of B12, pernicious anemia, which is an autoimmune condition, which means you might have antibodies that are directing themselves against something called intrinsic factor, making it very difficult to absorb B12. And there's malabsorption conditions. There's lots of malabsorption problems. You can malabsorb any number of nutrients and have several anemias at one time. And then surgery, like gastric bypass surgery, these patients are always now malabsorbing because of the structural changes to their intestinal tracts for weight loss purposes. So they have to take B vitamins, they have to take B12, they have to take iron, a lot of additional supplementations just to break even. And it's very difficult in some cases to do that. As far as the labs go, when you have a B12 anemia, you want to check B12 levels. You also want to check folic acid levels because those two work together. Folic acid is abbreviated B9, and we also want to measure methylmalonic acid and homocysteine. When B12 and or folic acid are deficient, both homocysteine and methylmalonic acids increase. So for example, with homocysteine, you see that elevated, you see a megaloblastic cell, and you're like, well, is that B12? Is it folic acid? Is it B6? It actually could be all. So you look at the blood test and homocysteine's elevated. B6, B12, and folic acid anemias will cause homocysteine and methylmalonic acids to increase. And these are damaging compounds associated with many diseases. So elevated homocysteine is associated with dementia, with heart disease, with certain cancers, autoimmune diseases. So we're going to do the peripheral blood smear. We're also going to do a CBC, the complete blood count. And in these particular tests right here, if the B12 is normal level and the folic acid is deficient, then we know the megaloblastic anemia was from not enough folic acid. That's just to give you an example of how doctors read these tests. Some of the symptoms of B12 or megaloblastic anemia include fatigue, numbness and tingling of the fingers or the toes. That's a giveaway. That doesn't usually happen with iron anemia. And also we have weakness, pale look, and also jaundiced skin. And what we're looking at here is a B6 anemia, which is called a sideroblastic anemia. So B6 could be made deficient in those that are alcoholics or just drink too much alcohol. Not only will you lose lots of B vitamins in general, but particularly a lot of B1 and B6 in the urine. You might have genetic disorders where you're not metabolizing or you need more B6, genetic conditions that result, let's say, in high homocysteine, and also inadequate dietary intake of foods rich in B6. So the labs would be a serum or plasma B6 level, homocysteine, which if elevated lets us know that there may be a B6, B12, and or folic acid problem. And we'll have weakness and neuropathy, fatigue, irritability, but the neuropathy and the irritability are two key findings that are most often seen in B6 anemia. And then there's protein anemia. So that could be caused by low protein intake, malnutrition or malabsorption of proteins, and chronic illness, which causes a hyperutilization of proteins. So you want to look at the total protein level in the blood, as well as albumin. I should have also put next to albumin globulin, because the total protein is the total of albumin and globulin. And if you're low in albumin, you might have a difficult time transporting some nutrients and hormones and medications to tissues. And if you're low in globulin, you'd want to do another test to see, well, which globulin are you low in, or maybe it's more than one. There's immunoglobulin A, there's immunoglobulin G, there's immunoglobulin M, for example. So very, very useful tests. Fatigue, muscle wasting, pallor, weakness, and again, the muscle wasting will be obvious in someone who has a true protein anemia. And then there's vitamin C anemia. Low vitamin C intake leads to poor iron absorption. So if you're a vegetarian or a plant-based diet person and you're consuming foods that are supposedly rich in iron, that are plant-based products, that's not going to help prevent and or correct an iron anemia. The type of iron in these plant foods are called non-heme iron. Now, if you eat these plant sources with vitamin C, or foods with vitamin C, that will help convert the non-heme iron to heme iron, which is very absorbable, and that's what red meat has, or chicken or fish. Also, there's malnutrition and malabsorption that will make people vitamin C deficient. So you'd want to measure their plasma vitamin C levels, and urine vitamin C is even more important. So if you spill some vitamin C in your urine, that usually means your tissues are saturated with vitamin C. The vitamin C plasma test only tells you your vitamin C intake for maybe 3 to 4 or 5 days. And then you want to do a peripheral blood smear, because we want to see if there's large red blood cells associated with a low level of vitamin C. And if that's the case, it could be a vitamin C anemia. And the person might also have in their urine urinary dehydroascorbic acid at high levels, which means the body's turning vitamin C, the antioxidant form, into an oxidant form, and you'd want to correct that. Because if you want vitamin C as an anti-inflammatory or an antioxidant, it needs to measure as an antioxidant. But when your body doesn't have enough of nutritional synergists, things that work with vitamin C to convert that used up vitamin C, which is now called dehydroascorbate, which is an oxidant, you will make your inflammatory conditions worse, with one notable exception. If you're receiving intravenous vitamin C for cancer, you want the vitamin C to be an oxidant. You do not want intravenous vitamin C to act as an antioxidant. That will worsen your condition. You will see if you do research on cancer and intravenous vitamin C, we know it kills cancer cells. Is it going to kill all cancer cells? No, but it works as an oxidant. And then we want to look at the iron panel, because if someone's, again, a plant-based person and they're low in vitamin C, they may be low in iron. And then we want to measure a complete blood count, which measures red and white blood cells and platelets. That's what the CBC is. And then in terms of symptoms, a person with vitamin C anemia may have bleeding gums, bruising, fatigue, and joint pain. So the bleeding gums and bruising, those are very consistent with vitamin C deficiency. And then the joint pain, very characteristic of vitamin C deficiency and not necessarily of other anemias. And then there's what's known as anemia of chronic disease or inflammatory anemia. So chronic inflammatory or infectious diseases will have this type of anemia: autoimmune disease, chronic renal disease, and malignancy. So in other words, these diseases affect nutritional status in such a way that it causes this anemia of chronic disease. Usually that anemia will be diagnosed along with other clinical findings where there is a elevation of CRP, C-reactive protein, and ESR. That's the erythrolyte sedimentation rate. Those are inflammatory markers. They are not specific, but they're general inflammatory markers. And then a person may have a low ferritin, which is a storage form of iron in anemia of chronic disease. If they're low in ferritin, they're usually low in iron because it's bound to ferritin, and ferritin itself is a protein and it's made from protein. So if someone has a low ferritin, you also want to check for protein anemia. And then there's the iron panel, which you always want to check when you're looking for an anemia of chronic disease. So you're looking for serum iron, TIBC, and transferrin saturation, along with a complete blood count. Persistent fatigue, shortness of breath, pallor and weakness, very, very common in anemia of chronic disease. And then there's hemolytic anemia, which basically describes how the red blood cell sort of kind of blows up. Literally crenates, they call it. And that can be caused by taking too much vitamin C in a person who has an enzyme deficiency known as G6PD. Now, many chronic diseases will cause a deficiency of G6PD. Your doctor can easily measure G6PD. It's a model top blood draw tube. It's covered by insurance. So you want to do that. So premature destruction of red blood cells due to autoimmune diseases, due to hereditary conditions like G6PD or acquired G6PD deficiency, infections, toxins, drug reactions commonly give hemolytic anemias. I didn't have a picture to show you, but basically you'll just see a bunch of pieces of fragments of red blood cells when you look under the microscope. And the key labs that let us know about the existence of a hemolytic anemia or hemolytic crisis would be the peripheral blood smear, which is number 3 here. And then there's LDH, lactate dehydrogenase. When cells break up, they release LDH, and that's a sign that this may be a hemolytic anemia. And then we have indirect bilirubin. Bilirubin also is strongly associated with hemolytic anemia. There's a laboratory test called Coombs test. I mentioned the G6PD levels a few times. We want to measure reticulocytes because we need to determine in hemolytic anemia if there's a problem with the production of the early progenitor cells of red blood cells, which are the reticulocytes made by the bone marrow. And then there's hemoglobin electrophoresis, which is a classic test for hemolytic anemia diagnosis. And then CMP, which is a very detailed chemistry panel. And then the symptoms could be jaundice, where the person is yellow. And if they stick out their tongue, very yellow, the top of their mouths will be yellow. For example, that's due to the bilirubin released due to the red blood cells breaking up, and the urine is typically dark colored. It'll be strikingly dark. There's weakness, fatigue, and also skipped heartbeats. So this is meant as a very quick run through of common anemias. So I would suggest that you print out or keep this power presentation, because if you suspect any of these tests I've given you, or any of these types of anemias, I've given you the type of test that the doctors should be ordering. But I don't understand why. Well, many doctors just don't know labs very well. And it's very strange. They should. But a lot of these different anemias might be diagnosed by different kinds of doctors that don't speak to one another. So it's good for you to know these types of tests and the basic symptoms and the signs and the causes of these anemias, so that you are the most prepared self-serving healthcare provider you can be. And if you have a friendly enough doctor, they will be open to these tests. If they're not, find another doctor. So that's what there is to say today about anemias. I hope you found this useful, and I'll see you at the next podcast. Thank you. So thank you for joining me for this conversation on herbs. A lot of you wanted to hear this. Some of you only want to hear the good things, but I have to be honest and sometimes say that nutrients, especially herbs, can be used and can cause greater problems than their original intention. Thanks for joining me, and I'll see you at the next podcast.